So I think we have a quorum for multidisciplinary discussion. I'm supposedly chairing this session, and I'm very glad Elizabeth and Vasilis have actually been able to extract themselves from a very busy clinic. Otherwise, as chairman, I would have been asking myself questions, and I'm not sure that I would have got very sensible answers. And it looks as if Dr. Molyneux is also on deck. So without further ado, Vasilis, I believe you're going to present cases.
Yep. Just a moment. So I must say that from previous experience, everybody liked this session on the basis of simulating what is happening in our daily practice. Not so often about sarcoidosis, but it does occur for sarcoidosis as well. So the first lady is a 42-year-old lady, non-smoker, who was referred to us in 2020 during the pandemic with a cervical lymph node enlargement and report of systemic disease symptoms. She had a known history of fibromyalgia since 2014. At the time and until the referral, she was on morphine and tramadol. And she reported having prominent fatigue and joint pains along with the cervical lymph node enlargement. This was her baseline blood test that showed normal ACE that was commented earlier today, mild lymphopenia, and slightly lower iron but good ferritin. These are her lung function tests, where you can appreciate that she has mild gas transfer impairment with TLC of 73% and normal spirometry with normal spirometric values. So I would not proceed to any further. I would like to ask Professor Devaraj to comment on her scan if it is possible.
Okay, thanks.
Stop sharing.
Thanks very much, Vasilis, and thank you for inviting me to take part in this fantastic event that you and others have arranged. So I'm just going to bring up the scan from 2021, if that's okay with you.
Yep.
Okay. And I'm going to share my screen in a moment. Okay. So let me know if you can see my screen.
Yes, we can.
Okay, so I'm just going to play through this series of images which represent the images from a CT scan of the thorax. And the way these are arranged is that you have to imagine as if the patient is lying on their back and we're looking at the lungs from the feet, from the base, if you like, and scrolling down through the lungs. So here we have the left lung and the right lung because we're looking from the bottom, if you like, upwards. This is the heart in the middle of the thorax, and these lungs either side are largely black because they are composed primarily of air, which is, of course, what our lungs are primarily composed of. And what CT does is it creates images based on density. So gas or air within your lungs is typically black, whereas more denser structures, such as the bones, are white. And here you can see, for example, the spine, and here you can see the ribs. So I'll just take you through the actual scan findings itself. And the first thing that I would highlight is that both lungs show not only the normal black bits of aerated lung, but also all these white lines and dots. And we refer to this in radiology as nodularity or reticulation. And this indicates that there is an abnormality in the lungs that is causing something, an infiltrate or an abnormality, an abnormal process to create something additional within the lungs that shouldn't normally be there. And in this particular case, these nodules that we see, what we refer to, these tiny dots, which we refer to as nodules, are in a distribution which is very characteristic for sarcoidosis. And we know that from our experience and from having seen many of these cases, that the distribution of the abnormalities here, as well as how these abnormalities look, tell us that that is the most likely diagnosis. Now, the other thing to say is, and that's important for you to, and the additional piece of information that's important for you is there lung fibrosis? So that, in other words, is there not just sarcoid, but is there also scarring of the lungs? And in this particular case, what we're looking for is these lines here, what we call reticulation. Now, what I'm also going to notice is the fact that the airways, which are the windpipe, if you like, which then branch into lots of smaller airways in your lungs, which are these little black holes here, are also rather abnormal looking as well. And that indicates there is a minor degree of fibrosis or scarring in these lungs. And we'll just go through just to make sure there's nothing else to talk about. Yes. And then the other thing that I think we should also comment on, if we have time, Vasilis, is the fact that the mediastinum, which is the central part of the thorax, which includes the heart, also contains lymph nodes, and lymph glands can become enlarged and calcified in sarcoid. And you can just see this little white spot here, and that indicates that some of the lymph glands in the middle of the thorax have also become affected by sarcoid. Okay, thank you.
Anand, just chairing this, can I ask you at this stage how confident you are about the diagnosis of sarcoidosis?
Yes, so some sarcoidosis can look like many different things in the lungs, and this is one of the more common appearances. In actual fact, this is not just more common, it is very classical. So there is not really any other differential diagnosis that one would entertain. This is highly suggestive of a diagnosis of sarcoid. And the reason for that is, as I said earlier, the distribution of these tiny dots or nodules.
Okay, so Anand has basically said no other diagnosis is plausible. So before Vasilis, you go on, can I perhaps ask the other clinicians, yourself as well, whether you would actually recommend any other tests at this point for diagnosis, or would you regard the diagnosis as definite?
Elizabeth, would you like to go first?
Sure. So yes, I think hearing Anand say that it is there isn't pretty much a differential diagnosis, although usually, I mean, by definition, sarcoid is defined by the presence of granulomas. We do recognize that when CT is classical, when the pattern on CT is classical, we don't necessarily need to move on to histology. And hearing what Anand has said, looking at the CT, I would say that we would have, at the very least, a high confidence diagnosis of pulmonary sarcoidosis. We have the lung function test, we've got the lymphopenia, the ACE level was just at the upper limit of normal. I would say we could reach either a high confidence or a definite of sarcoid.
Well, I think we would say it's 95% likely plus, wouldn't we? Adam, that's a fair call. And
I think that's right. Yeah.
So you and I,
so
would be going to the patient. We would be explaining we never quite reach 100%. We would be explaining that we would anyway be following the situation to pick up in the short term anything that then suggested a different diagnosis. And I think most patients would choose to avoid a bronchoscopy. I found that over the years. and would actually choose to accept the 95% with follow-up. We've moved away from the 1980s when the physician arrives in the room to the strains of the arrival of the Queen of Sheba and declares that there's going to be a biopsy. So I think this is very much, isn't it, a negotiation at this point. But we would not be twisting anyone's arm to have a biopsy, right? Vasilis.
Prof, I completely agree with you. I think that the biopsy wouldn't really add anything on this case because we are definite from a lungs point of view. But if we had to biopsy something, I imagine that we would go for the cervical lymph nodes that are quite easily accessible.
Yeah.
This patient had very clear cervical lymphadenopathy. Phil, would you also agree?
Yeah, no more tests needed here. The presentation, the imaging, there's also lymphopenia on the blood tests, which we know go to the diagnosis of sarcoid. Lung functions well preserved, would do no further tests at this point.
By the way, the patient had a cervical lymph node biopsy with non-necrotizing granulomas prior to the referral. So one of the questions that I had, I think, have been answered. I think that we're coming the two first questions. The question that I have, which is the most important one for the panel, is would you treat this patient? And before you give me your answers, I just wanted to ask Anand. Anand, in the one of the presentations that I gave earlier, we went through the clinical radiological staging that you were part of, where we had CPI, extent of fibrosis, and mean pulmonary artery to ascending aorta ratio as the key determinants of risk. So you did mention fibrosis, limited in extent, if I recall, for this case. What would your comment be about extent of fibrosis and based on that radiological staging? And then Athol, over to you about the answer about treatment.
Yeah, so I would say that there is a limited amount of fibrosis, not extensive. Most of the abnormality was not fibrosis. And then the other part of the staging, as you mentioned, was the pulmonary artery. Was there evidence of what we call pulmonary hypertension? And sometimes you can detect that the blood pressure in the lungs is raised because the blood vessels in the lungs are bigger than they should be. But in this case, that wasn't the case.
Okay, so I think probably I should ask the others to comment on treatment, adopting the privilege of being a chair. So this time it's Phil's turn to speak first, and Elizabeth will then have the last word.
Phil will have to admit that I can't quite tell you how bad the symptoms were that the patient presented with, because the decision to treat is based on organ damage, potential for organ damage and symptoms. The CT scan is quite spectacular and impressive. The lung function is very well preserved with only minor impairment of the gas transfer. So I think if the patient was entirely asymptomatic, there would be a discussion on treatments and the benefits of potential treatment. But if the patient has symptoms from a respiratory point of view, then I would definitely treat at this point.
So Phil, the patient doesn't have any respiratory symptoms, but she does have prominent joint pains and fatigue with quite enlarged cervical lymph nodes at presentation with this scan. That's the main thing that, yeah.
So, I mean, at that point, I would be recommending treatment, given the symptomatic burden and the radiological burden that was present there.
Elizabeth.
Yes, I think I agree with Phil. You would not be treating for lung impairment despite the diffuseness of the abnormalities on CT. Her lung function is actually almost normal, so you wouldn't be treating for that. You would be treating for symptoms and the lymphadenopathy that might be causing her problems. And therefore, I would discuss with the patient whether a further period of observation would be her preference, or whether she would want to go for a low dose of prednisolone, maybe to be tapered relatively quickly, and hydroxychloroquine as a more long-standing for the next year or two, just to see whether it helps with the joint pains, with the fatigue. As we've heard from the excellent talk today, there isn't any treatment that has been definitively proven to help with fatigue, but hydroxychloroquine there is some very low evidence that hydroxychloroquine might help with that, and it can help with joint pain. So those would be the discussions. But equally, we could decide with the patient not to treat if she is absolutely against having steroids, which many patients, of course, are, because they are concerned about side effects, weight gain, etc. And so it would be a nuanced discussion, because at the moment we're not worried about her lungs or other internal organ involvement.
Well, we're not, because on lung function for danger, the lung function levels are way, way, way above the high risk area. The scan may look bad, but granulomas that are inflammatory in all of the CT studies have not really impacted on lung function. So your only concern would be evolution to scarring, and you would be watching for that, especially as there's a bit of a scarring signal there.
Absolutely, and of course, if she decides
so I mean, for danger, we've got a duty to set it out and make recommendations. When it comes to quality of life, I really think that the person who has the impaired quality of life simply needs to think through very carefully whether they feel they need to try a symptom, or whether they would a treatment, or whether they would prefer to leave it for the moment and give it a chance to improve. The problem is, I think we all agree, you can't do a blood test and find somebody has 13.7 units of tiredness or 7.2 units of pain in their joints. So this becomes very much, I think, ideally, a patient-driven discussion. So we would not be making formal recommendations before that when it comes to quality of life. Vasilis, do you have any other questions on this case? Further investigations before considering treatment? So let me put it to Elizabeth and Phil. Anything else you need to know?
I don't know if Phil wants to answer.
Well, no, I asked you first.
Oh, sorry. I think if she doesn't have any symptoms, where she doesn't, they're not mentioned, suggesting any concern about the heart, and her routine bloods we've seen are all normal, no, I don't think we need any further investigations. And it's just a question. And just to add to before, of course, if we decide together to opt out of treatment for the moment, even more important to monitor carefully, just to make sure, like you say, there is a little bit of a scarring signal that doesn't get worse.
Okay, Phil, any addition at this point?
No, nothing else
so
from me.
let's keep going.
So the patient was not treated, and this is her serial lung function test. And as you can see, there was a slight decline after a while in her gas transfer values, not particularly significant compared to the baseline. A slight decline in her FVC. Unfortunately, we don't have the second scan because we had to anonymize it, so we had only one scan for every patient. But there was more nodularity Anand, do you want to comment on the second scan, although you don't have it, just to comment on what it showed?
I'm sorry, I don't have that Vasilis, so I can't comment on it.
Okay.
So we can
Okay.
take that on trust. Vasilis, are you wanting to stick with there's a real change on that lung function?
So not for gas transfer. The spirometry, it was slightly lower, but it is within normal limits. So we wouldn't really consider this as significant change.
Yeah, the point there is you never get identical numbers. The machines vary. So there's always a degree of change, which often is well below the threshold where you know that it's real.
The patient doesn't report any additional symptoms from a respiratory perspective, continues to be troubled by systemic symptoms. No treatment has been started. But then as part of the systemic symptoms, he reported palpitations. So we did a Holter monitoring and when she reported palpitations, her GP gave her steroids, 20 milligrams. She came down to a prednisolone dose of 5 and then had an MRI and a PET scan, which actually detected cardiac involvement. As discussed in our cardiac sarcoidosis MDT. There was no evidence of active myocardial inflammation, but this is the PET scan that we have been informed about because it was performed outside our hospital. There was intense inflammation in the lungs. So I'm just coming back to you with, so a decision was made not by us to give this patient a treatment, low dose treatment, season 5 milligrams of steroids, because the GP was concerned about the heart palpitations. The MRI did confirm cardiac involvement. It is the same patient with the overt nodularity on CT. And would these findings change your views about treatment?
Perhaps I'll answer a question first on this occasion. Vasilis, I think I'd want to know the result of the Holter monitor, certainly.
No VTs, some ectopics, but nothing really.
So just ectopics. A lot of the time palpitation.
Athol, we can't hear you that well.
Okay, can you hear me now?
Yes.
You can. A lot of the time palpitation are benign, especially when they're occurring at rest rather than on exercise. So I think with that Holter, you don't have a reason to treat because of a rhythm disturbance driven by sarcoid. You're allowed to have over 1,000, well over 1,000 ectopics a day and be normal. And there isn't damage in function. There's very, very limited scarring, which is probably a footprint of some past inflammation, and nothing to indicate activity on the PET. So no, I wouldn't be using the cardiac profile at all to drive additional therapy. But I think putting it to the others, we've heard that there's increasing nodularity. The patient has been started on prednisolone. What would you do at this point? Would you continue? Would you use a higher dose to take full control? Would you withdraw? And I guess we want to know if the patient noticed an improvement in symptoms with the treatment.
I'd have to say at this point, if presuming that there's been some progression of symptoms because there's been a lot more tests, so I'd imagine that there'd been some progression. There's been a drift downwards of lung function within normal ranges and within margins of error, but all the things are stacking up now, and we're almost left in a no man's land at 5 milligrams of prednisolone if we think this is active disease. So I'd be having a conversation with the patient as to what we were hoping to achieve, because I feel like we're neither treating or not treating really, so we're stuck somewhere in the middle. And at this point I'd probably be favouring looking at other drugs like methotrexate and coming off steroids, or potentially increasing the prednisolone, albeit that I'm very conscious of the side effects of prednisolone, and that methotrexate's often tolerated very well. So those would be the kind of decision points that would be going through my head, because we're in the middle of nowhere really at the moment, I feel.
Elizabeth.
Yes, I think it's a great case, because it's one of those 50-50 decisions. I think, although, with no degree of incredible certainty, so again, it would be a discussion with the patient, but like Phil, I think I have more of a tendency towards at least discussing treatment, and that's because the PET scan shows intense inflammation in the lungs, the CT shows worsening of the diffuse nodularity, and there's been a 10% drop in the FEV1, almost 10% drop in the FVC. And so if I put all that together, I think, and we don't know her pre-sarcoid lung function. Was she someone who was way above the norm, and so has she lost, and we're being falsely reassured by normal volumes? So I think if I were to treat, and again, this would be a discussion with the patient, because it wouldn't be a terrible crime to wait a bit longer, but if we do decide to treat, I think I would go for a higher dose of steroids just to see if there is reversibility. So go for a treatment dose of steroids, review the lung function again after 3-4 months, 4-6 months, and see, no, actually 3-4 months, and see where we are. If there is a significant response, then I tend to taper down, and if needed, introduce a steroid sparing agent, and would just look at treatment just to see how much reversible disease there is and where we get to. But again, it's not a secure decision. So it would be following a discussion with the patient again. It's marginal.
Well, we've got 2 more minutes. I'll just make a couple of points to add to what you've said, I think. Firstly, we're effectively treating for 2 reasons, and quite often there's half a reason to treat because you're worried about damage and half a reason to treat for symptoms, and they can add up to a good reason. But one of the pluses of starting with a high dose is to find out if the symptoms and quality of life responds to sarcoid therapy, because otherwise you can drift into doses that are not quite effective and just build up side effects over the years. And yeah, I'd be a bit nervous with the bulk of inflammation getting worse. I'm not impressed by the lung function trends because I think they are so within the range of measurement variation. But I am worried about the extent on a scan, the fact that it's worsening, the PET is intense. So you're starting to play at dice, aren't you, in a way, if you don't intervene. So I think this would be a consensus amongst us. And then one final issue, very often you need to switch off inflammation, and once you do, civilized therapy can prevent it from recurring, but it won't take control by itself. So I think there's a big plus for switching it off of a short, sharp burst in the first place. Well, we've got 1 minute to go, Silas. I don't think we can do a second case in a minute flat. So I will just ask, I think, Phil and Elizabeth, whether they have any other editorial comments to make about this case.
Athol, I would like to ask all of you, based on your experience, because what is very interesting, and this has been one of the main concerns of the patient, is that she's concerned that actually her condition has progressed to that extent that she had cardiac involvement, she had fibrosis on a scan, and we were holding our guns, or we were actually not treating her on the basis that the lung function was normal. So she was concerned as to whether in the beginning of everything, even being asymptomatic from a cardiac perspective, should we have actually treated her?
Well, let's deal with the heart side. 30% of people with sarcoid will have evidence that they've had some past inflammation in the heart. The function is normal. The scar burden is trivial, actually, in its extent, and there's no activity. So for the heart, all I would do treating that is provide side effects. There's nothing to suppress. You would monitor that, but you wouldn't treat on those grounds. Now let me turn over the question on the lungs, which is actually the more complex question. So I think our panelists should have the opportunity to excel.
I guess I'll start, Phil, and then you can. I guess well, we haven't seen the second CT scan, but from what I understand, it's mainly an increase in the nodularity, and the PET shows intense inflammation. So there is nothing to suggest that we have. And even in the first CT, because we have to go to the first decision, the first CT, there was very limited scarring, and the majority of changes were inflammatory. And we know nodules are reversible. They can be spontaneously reversible or reversed with treatment. So I guess what I would be thinking is, even with the benefit of hindsight and looking at the current CT and PET, the disease remains mainly inflammatory. And so we haven't lost time to prevent irreversible fibrosis, from what I've heard from the CT reports. And the situation would have been extremely different if there had been already significant fibrosis at presentation. But Phil, I'll leave you to comment further.
Yeah, I mean, from a cardiac perspective, I'm entirely happy with the decision not to treat at the beginning. I think the decision to treat earlier on is very difficult, because we're now looking at something in hindsight with some signal that things have progressed. And these decisions aren't easy, because the CT scans are very impressive. But we do know historically through large numbers of studies that scan on its own does not necessarily mean there's going to be progression when you have good functional reserve. So that's why I say it's often quite important to focus on the symptoms at that point, because as Elizabeth's alluded to, not everybody has lung function of 100% when they're well. Some people have a lung function of 130%. So if you've got somebody who's highly functioning, young, athletic, who's suddenly noticed a decrement in their ability to walk, exercise, do something else, they're more of a signal to push us to treat. So it isn't a straightforward, see a CT scan, start treatment. And often, if there isn't a signal a patient notices, then there's often not a signal to treat, and the reception of treatment is not as good. So I'm trying to say in a complex way, there isn't a right answer. I think, if I'd seen this case as a history referred to me in clinic, I would have not had any problems with the management that we've come up with, any of us. I think that's just a variability that we see.
I agree with you, Phil. I wouldn't have had any issues whatsoever. It's a balance of risks. What is the greater risk? Is the greater risk to actually give people side effects with treatment that is not needed? We know that treatment-related morbidity is a big deal in sarcoidosis, and once you start therapy for lung inflammation, you may be on it for quite some time. So if it's not necessary, that's an extra risk by intervention. And against that, what's the chance that you will get damage developing that is major over a short period of time that you could have prevented? And I think that I too would have said the greater risk here at the start was actually causing trouble with therapy. Now that doesn't apply to the symptomatic side, that's a separate question. Okay,
I think, Prof, the only thing for me to comment as more of a cardiac sarcoidosis side of things, I think that the main thing that changes our views is the evidence of cardiac involvement. And I think that this case very clearly illustrates that we don't really know the spectrum of cardiac sarcoidosis and how often this could be complicating things. So I think that what effect this did have on me was that this particular case was in a patient where I have active pulmonary sarcoid, even if I don't have strong evidence or I am not keen to treat because the patient's lung function is normal, or for any other reason, the patient doesn't want to, etc., etc. I will always be thinking about the heart in these particular patients more closely. Maybe an echocardiogram or maybe a BNP test may be important as screening tools nowadays, rather than dismissing patient with a normal ECG as the guidelines say at this moment in time.
Yeah, I agree with that, because especially if you've got symptoms from the lungs, you may be losing guidance of symptoms coming from the heart. So when you say ECG screening, you also really mean ECG plus asking for symptoms, including breathlessness, that might reflect cardiac involvement. Now, if you've been robbed of an ability to interpret breathlessness, it really does justify looking harder with other things. I mean, it was your study that established that about 30% do have some often trivial damage on an MRI scan related to past events. And I don't think you're suggesting that finding this on this scan in any way influences treatment decisions. But I do agree with you, people need to have a high suspicion of cardiac involvement. It's easy to miss.
Thank you. Thank you everyone for participating. Thank you, Anand, particularly for taking your time and anonymizing 3 studies, because we had 3 patients prepared. Thank you, Elizabeth, for joining.